pain psychology is not the when everything else fails intervention because you just must be crazy. No, like it's really meant to be a first line treatment. And if it were being offered sooner, in part because we have limited resources, we could really help people early on in their pain journey.
World of Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information in this website. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome back to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derick Davis, a physician specializing in pain management. In this episode, we speak with Dr. Samantha Meints, a clinical pain psychologist. Dr. Meints received her bachelor's degree in psychology at Butler University and then went to Purdue University, where she obtained her PhD and is now a clinical psychologist and an established researcher at Harvard Medical School and Mass General Brigham Hospital. In our conversation, Dr. Meints breaks down what it really means to be a pain psychologist, dispelling myths like your pain is all in your head, and explains how stress, trauma, and even negative thought patterns can amplify pain. She shares a personal connection to the field, having suffered from psoriatic arthritis since she was 11 years old. We'll explore how therapies like CBT, ACT, mindfulness can help patients regain function, reframe a relationship with pain, and even reduce its intensity. And we'll talk about why there are so few pain psychologists, what barriers there are to access, and the practical steps anyone can start today to better manage their pain. So let's get into it. And as always, thank you so much for watching or listening. I hope you enjoy this episode and learn something. Dr. Meints, thank you so much for being here. We can go ahead and get started. First of all, I appreciate your time and thank you.
Yeah, thank you so much for having me. I'm excited to be here.
So you're a clinical psychologist. Your focus is on chronic pain. What is a pain psychologist?
So a pain psychologist gets the traditional clinical psychology training, either through a PhD or a PsyD. So it's doctoral level training. And then we have a specific focus on usually health or behavioral medicine. And then for me and for pain psychology specifically, it's even more narrow, specific training on how to work with people who have acute and chronic pain conditions. And that's really just understanding mind-body connection. And, a little different than what people generally think. Getting referred to pain psychology does not mean that you're crazy or that your pain is imaginary or all in your head. Although I admit sometimes there may be some doctors who do believe that, but that is not generally the case. So we're really just trying to understand how the mind and body come together to produce these sensations of pain, and then how we can harness that to help people better cope with their pain or overcome their pain entirely.
Was it that mind-body connection that got you more interested in chronic pain, or what got you interested specifically in the subfield of chronic pain?
Great question. I actually have had chronic pain most of my life. So I was diagnosed with psoriatic arthritis when I was 11. And saw a lot of pain in family members who also had that condition and were dealing with that lifelong. So I think that had given me a lot of early interest in general in medicine. And then I went into psychology thinking that I would be doing something a little bit different. I really started studying autism. I took one health psychology class. It was my first class in grad school. The professor, Dr. Hirsch, ended up being my primary mentor. And he is a pain psychologist. I fell in love with what he was doing, and I never turned back.
So you can sort of relate to patients on a very personal level then.
Yeah, I can. I understand what it's like to have a condition that will not go away. that you can manage, but that really requires a lot of behavioral management. And I've personally also seen how things like stress and anxiety have impacted my own personal pain experiences. And that when those things are better managed, my pain is a lot better.
That kind of leads us into our next question. So what are some common psychological factors that contribute to chronic pain?
The big ones that most people know about: stress, anxiety, depression, trauma. All of these are known to amplify pain. We know that fear of movement is also another big one. People often avoid activity because they're afraid it's going to hurt and cause more damage, which can actually make things worse over time. And then the last big one is pain catastrophizing, which is a terrible term. So I will refer to this as negative pain thoughts. These are just automatic thoughts that we have about pain. Things like, this pain is never going to get better. There's nothing I can do to make it get better. And I can't stop thinking about it all the time. Those are all associated with worse pain outcomes.
When a patient comes to see you, how do you assess each one of those psychological comorbidities? Because I imagine sometimes they're not even diagnosed before they see you. Maybe that's depression or anxiety. So how do those things come up naturally, or do you use scales, or how do you assess them when they first come up?
Yeah, so the most common ways that we do that are through interviews and also some questionnaires, usually validated questionnaires. It's important to ask about patients' whole life from childhood on, rather than just focusing on pain and their body, the sensations they're feeling. We're really trying to get a very broad picture. We ask about their mood, their relationships, work, other stressors that they might have, as well as other health conditions. And we're not just looking at problems, right? We also want to identify strengths that the person has that we can capitalize on in our treatment with them. So again, we're asking those questions. How are they feeling today? How have they been feeling lately? Do you have low mood or feel depressed? What kinds of things do you enjoy? So looking at the opposite of that. And then also really assessing for trauma, especially in childhood, understanding if they experienced abuse or neglect, or other particularly stressful situations early in life. And then what does that look like nowadays? Have they received therapy related to that? What's their mental health history look like, and their treatment history along with that?
The things like PTSD, stress, anxiety that you're mentioning, how do those impact pain? Like, I remember I listened to a podcast you were on, and you were talking about how there was a research study in which someone inoculated healthy volunteers with the cold virus, and then some of them developed it and some of them didn't develop like a cold subsequent to that. So, is your emotional state impairing your immune system such that you then are more susceptible to infections that, relate to pain? Or how do they relate to pain in that regard?
You're exactly right. That is one of the ways that our emotions are linked to pain. But I think a step before that is that we need to understand, what is it that emotions are doing? Why are they important? Emotions drive behavior. Anxiety and fear help us to avoid or respond to stressors. Anger helps to protect us when our boundaries are violated. Love, empathy, guilt, even grief, they help to promote social connection and cohesion, which is really important for people who live in a communal society, which arguably we still do, and we used to a more of an extent if we're thinking, 100 years ago.
Yeah.
So these emotions are really vital to keep us alive. They are meant to perpetuate our existence. The areas of the brain that are responsible for processing pain also process emotions. So when you're anxious, angry, your nervous system is sensing some threat, is on high alert, and that can amplify, or in some cases even cause, pain signals as a way to get you to pay attention. And that works really well for acute pain, like if you step on a piece of glass, but not so much for chronic pain. Those processes that happen from that initial warning signal can also change things like inflammatory processes, which is why, and immune processes, which is why we see that there can be, under acute stress, we see more pain, but we also see like inflammation markers go up, and that autoimmune processes happen. As I mentioned, I have psoriatic arthritis. That is an autoimmune disease. When I am under stress, that spikes both in pain, but also in those immune markers.
So complicated. It's all intertwined. I think, the brain is so powerful, and I don't think we give it enough credit. I think in the United States, we, focus, we were talking about this earlier, focus a lot on the mechanistic or mechanical aspects. My knee hurts, and I have a knee joint, and so it must be something with my knee. And I wish that we could incorporate more of just the brain body connection. And I think we're getting better at that. Are there certain demographics of individuals that are more predisposed to chronic pain, or is it kind of just across the board? These emotional states just impact pain.
So what we see is that these emotional states also are more common in certain demographics, which likely is facilitating some of the disparities that we see. But there are definitely significant differences in sex and gender, as well as race and ethnicity. We know that there are minimal sex differences in pain prior to puberty, but from that point on, females experience significantly more chronic pain than males. And this is not just for pain that's female specific, like endometriosis, for example. This is for other chronic pain conditions as well. Older adults tend to experience more musculoskeletal pain than younger adults, which makes sense. Their body is aging, and we see like a functional decline with that. But other more centralized pain conditions like migraine, fibromyalgia, chronic pelvic pain, those peak at a much earlier age. There's also lots of racial and ethnic differences in pain. Generally speaking, people of color have worse pain and function than white people in America. And in Native Americans, actually, they have the highest rates of chronic pain. And Jamie Rudy is a researcher out of Tulsa. And he really studies pain among Native Americans and has really looked at this. And the rates of chronic pain are significantly higher in Native Americans than they are in the rest of the U.S. population.
Are there any socioeconomic differences that we see as well?
Yeah, of course there are. And unfortunately, so inherently tied, right, to the racial and ethnic disparities. These socioeconomic differences often are shown to be related to differences in access to care, but also related to greater exposure to traumatic events earlier in life, and chronic stressors more broadly. So again, predisposing those folks to having greater pain response later in life.
Then transitioning to sort of some of the modalities that you incorporate into your practice, things like cognitive behavioral therapy, and then, I think most people are pretty familiar with CBT as being mentioned, maybe not familiar with what it stands for. And then some additional ones like ACT therapy and DBT, which is dialectic behavioral therapy. How do those help chronic pain patients?
Yeah, so in psychology, we generally love our 3-letter acronyms for all of our therapy and therapeutic interventions. So yeah, you've got CBT, cognitive behavioral therapy, acceptance and commitment therapy, or ACT, DBT, dialectic behavior therapy. And there's a couple of newer ones that are pain focused as well. So pain reprocessing therapy, PRT, an emotional awareness and expression therapy, which violates the norm and is a 4-letter acronym. So EAET. In general, these all take slightly different approaches, but their focus is on identifying maladaptive thoughts, emotions, and behaviors, and using some strategies, some really like skill-based strategies to overcome those or to work against those problematic or less helpful tendencies in order to either better cope with pain, to function better with pain, to decrease the actual, volume on the pain. So can we actually decrease the intensity or severity of the pain? And in some cases, proposing that we can get rid of pain altogether. So it's a mixed bag of exactly how they do that. They all have their own little nuanced differences. But in general, there's a lot of similarities of identifying what's not working and trying to focus on maximizing what is working and moving away from the things that might be facilitating keeping people in the cycle of chronic pain, which is more pain, less activity, worse mood, more anxiety, which feeds into worse pain. The worse the pain, the less active, and so on.
That pain-related fear or the avoidance behaviors, how that becomes sort of a cyclical process. Is there a name for that process?
It's just sort of like the fear avoidance model of pain. This is also like, it also is known to perpetuate anxiety and anxiety disorders. So these things kind of run in parallel. And it makes a lot of sense, right? Like acute pain, as I mentioned before, is a warning signal. It helps us avoid injury or brace ourselves in order to heal from injury. And so it says, don't do anything, rest. Great. That works awesome if you have a broken arm and you just need to let it rest to, have it set and heal. It does not work for chronic pain. And so what happens is that we spend time sedentary or resting. And during that time, we decondition. We lose strength and mobility. And then when we go back to try and engage in activity again, now it's even more painful because we're lacking strength. It's just like that first time you go back to the gym after taking a prolonged absence. It's going to be sore. But when you already have pain, your body and brain are registering that as danger. And so it keeps you from engaging. The last thing you want to do is make the pain worse or make the injury worse.
Right. And our body and our mind sensing pain does not necessarily mean worse damage to our body.
Yeah, it's not a one-to-one, right?
Right.
There's all of these studies that have been done, a lot of imaging studies especially, that show among the people who have chronic back pain, for example, less than half of them will have radiographic findings on some imaging. But the flip side is also true. If we put in a bunch of people who don't have back pain, there will be a substantial subset of those people who do show some sort of pathological anomaly in their back. And so it's not necessarily that there's that direct relationship between the physiological tissue damage and the pain output.
That is a very hard aspect to overcome in clinic when you have an MRI that has findings that that are not relevant, but still sound bad, like degenerative disc disease. So many of us have that, but it may not be a part of the pain.
Yeah, I saw it explained in a really cool way recently. Which is degenerative disc disease is really just aging. And we expect our bodies to age. It's not a problem that we develop wrinkles. It's not a problem that we develop gray hair. And it's not necessarily a problem that we are, that our discs are degenerating. It's not always the problem.
Right. Absolutely.
with these modalities that you implement to hopefully help break this cycle and optimize quality of life, are there goals you set with each individual modality or overall goals? Because as you mentioned earlier, sometimes the idea being complete pain relief, and sometimes that's just not possible. And so, especially with chronic conditions. So how do you set or implement goals when it comes to these modalities?
That's a great question. It also comes back to which modality are you going to use with which patient?
Okay.
And so cognitive behavioral therapy, or CBT, the goal for that is really to improve function while also decreasing the intensity of pain. So you're doing things that are going to get the person back engaged in meaningful activity. So we usually talk about increasing some amount of gentle movement. We're implementing relaxation training, which is different than mindfulness or meditation. It's really meant to calm the central nervous system down. So we're talking diaphragmatic breathing, progressive muscle relaxation. They're a little bit more active in style for these relaxation strategies. So if we can do that and help to consistently calm the nervous system down, that should also turn the volume or the intensity down of pain. We're identifying and reframing unhelpful thoughts about pain. We're focusing on improving sleep, for example. Those are kind of the goals around CBT. Where on the other hand, goals around ACT, or acceptance and commitment therapy, are on being mindfully present. So paying attention on purpose without judgment to the thoughts that we're experiencing, our emotions, and the physical sensations in our body. Identifying the things that we value the most, and engaging in those meaningful activities. And so it's less about, in fact, it's not at all about turning down the volume on the pain, but entirely about engaging in the things that make your life worth living. And then you've got some of these newer therapeutic techniques like PRT, EAET, where the goal is to turn the volume down on the pain. And maybe that's turning it all the way off. Admittedly, I'm a little bit skeptical of this. I've seen it work in a handful of patients, but I think more often what we see is that it can really help to turn the volume considerably down. This is in general for people who have some amount of nociplastic or neuroplastic aspect to their pain. So what's really important to note about that is that pain can start from a very real tissue damage injury. If it continues past the point of what would be considered normal healing, chances are it has become, at least in some capacity, neuroplastic or nociplastic. So can we help by using those strategies to help with that aspect of the pain that is developed? Simply by having pain for a long time, your brain activates these pain pathways, and those things stay active despite input from tissue damage. And so we want to see if we can help use neuroplasticity to downregulate those signals.
And you mentioned something like diaphragmatic breathing. Does that fall under the mindfulness category?
Not exactly. So it can, but let me take a step back and define mindfulness. Very specifically, mindfulness is paying attention on purpose without judgment. There's nothing you're doing in mindfulness other than the paying attention part. So you can do mindful eating, where you explore a piece of chocolate, you look at it, you smell it, you put it in your mouth, and you don't swallow it. You just taste it. And you might notice the urge to swallow or to chew, right? And you just don't do it. So you're paying attention on purpose. You can walk mindfully. You can scan your body mindfully, and you can breathe mindfully. When you're doing mindful breathing, you're not trying to change your breathing. You're just paying attention to what it's naturally doing on its own. Diaphragmatic breathing is deepening and elongating the breath. So slowing your breath down, using the diaphragm muscle to expand your lungs fully. This is actually the opposite of what happens in the fight or flight response, where our breath gets shallow and rapid. So we're trying to purposefully counteract that with diaphragmatic breathing.
I used to do what was called the square breathing. I think it was, is that again, sort of one of this sort of falls within that CBT sort of purposeful way in which you engage the parasympathetic, or at least reduce some of the sympathetic tone?
That's exactly right. So anytime you're trying to change the way you're breathing, so square breathing is a way to encourage that like elongation of breath. The same with, sometimes it's counting. Sometimes it's literally just like seeing if you can, how big you can expand your belly like a balloon. So anytime you're trying to change that, you're doing more of a relaxation practice than mindfulness. Mindfulness can be relaxing, but if another mindfulness practice that I can do is ask you to pay very close attention to the sensations in your body. And if those are painful, that may not be the most pleasant and relaxing experience to you. Or if I ask you to pay really close attention to like intense emotions, or to negative thoughts, it could be relaxing, but it probably isn't in those situations. But those things are often conflated. Now, mindfulness is also still helpful. What it does is it helps us to disentangle the physiological sensations, burning, shooting, tingling, numb, hot, cold, those kinds of sensations that are pain, with the emotional or cognitive aspects, the judgment of it, the sadness about it. What does this bring up for me? Am I sad that I'm going to miss my kid's baseball game tonight because my back hurts too bad to sit in the bleachers? Or can I just focus on my back has shooting pain right now? It's moving from my spine out to the right, but not to the left. And it's a little warm. Like that doesn't have anything to do with missing my kid's baseball game. And it's when I talk about missing that, like associate it with missing, that it becomes so much more distressing. So mindfulness teaches us to separate that out.
That's such an interesting insight, matter of fact, because like when I see patients in clinic and I'm like, tell me about your pain, they're often overlapped. It's like, oh, it hurts like, a knife, or it's sharp, and I can't go see, my daughter or my son's, game. And it seems like it's all part of it when you're trying to just, because we have, templates. We want to know about the 0 out of 10. What is your pain? What does it feel like? Everything like that. But it's also just overlapped that it's kind of hard to disentangle that. And so it'd be nice if I wish they had seen you first, and then I would see them later on, because that way you'd have a better understanding of what your pain's like. Because it's a lot to ask someone when they're already in pain, what's your pain feel like? And you're like, I don't know, it just hurts and fix it. And so I think that, slowing down and being able to describe pain before, you go see someone that specializes in pain treatment, I think would be so big, which I think kind of, this is kind of skipping ahead, but it leads me into some of the barriers there are and why there are so few pain psychologists. What are some of the barriers you see to seeing patients? And then why do you think there's so few pain psychologists?
So I think there's a couple of things here. So first of all, in terms of barriers to see those of us that actually exist in the system. So first of all, historically, stigma is a huge barrier. And in fact, it remains a barrier, not just in pain psychology, but we're really looking at the intersection of two sort of stigmatized identities. There is a lot of stigma around chronic pain as well. Even just being a person with chronic pain, right? Are you just drug seeking? Is this all in your head? Are you making it up? Are you trying to get out of work? Are you lazy? These are things I study pain stigma a lot. So this is something I've heard a lot, and especially in women who are thought to just be histrionic and overly emotional, and that's why they're in pain. So there's barriers to people even like wanting to come see us if they ever are given a referral, often stigmatizing. But historically, it would also need to be in person, which is really hard for people with chronic pain who have mobility issues. Nowadays, this is generally covered by most health insurance companies, although there's an overall dearth of clinical psychologists and mental health providers broadly, and a number of them don't accept insurance, and so it still creates another barrier. And it's time consuming. You're asking people to do this for roughly an hour every week or two for anywhere between 6 and 20 sessions if you're talking about one of these like very focused evidence-based treatments. But realistically, no one is the perfect candidate who just, I shouldn't say no one. Very few people are those perfect people who are going to make their way through 12 sessions of CBT and not need anything else beyond that, because they're complex and their condition is complex and their experiences are complex. So all of that comes into play, not to mention, the fact that this just doesn't exist everywhere. Even within, our own clinic, I have a pretty lengthy wait list. And so I think that there's just not enough of us to provide this, and the interventions are prolonged. It takes a while, to see improvement.
And why is it, do you think, that already there's, like, as you said, a dearth of mental health providers? Why are not more going into chronic pain?
I don't think that everyone knows about it. We know about mental health. There's a lot more knowledge of it, and that's the traditional pathway for, licensed social workers, other clinicians. But historically, only psychologists have been going into this sort of health psychology, behavioral medicine realm. And then especially pain psychology, you're getting more and more niche as you go forward. I also think that, working with people with chronic pain can be really challenging. There's a lot of complexity. And these patients oftentimes have been having a really hard time for many, many years. And understandably, they are tired and annoyed and depressed and anxious. And that is, and you add chronic pain on top of that, and lack of resources and all of these things. And it's a really tough population to work with. It's also incredibly rewarding, as you know, but it's tough. It's not, it's not a simple, you go in and you leave work at the door when you go home. Like, you take the stuff home with you.
All of those things make me sort of laugh at when we ask patients, 0 out of 10, what is your pain? Because, it's like a philosophical, very human condition, pain, chronic pain in particular. And so boiling it down to 0 out of 10, I don't know. There's no other better way of tracking it, though. I mean, we have to have some sort of objective data. That kind of is the basis by which, science and a lot of things work. And so we have to ask 0 out of 10, but it's often very challenging, and there are very complex scales that you could use, but it's just not realistic. It's not practical to test those each time. Are there misconceptions or myths both on the patient and provider side that you would like to address?
Well, I think, first of all, pain is always subjective by its nature, by its definition. It's also both a physiological and emotional experience. If you look up the IASP definition of pain. So to think that we can separate those things out, it is not realistic, first of all. And like, seeing pain psychology does not mean that pain is all in your head, or at least not in the traditional sense. Pain is always an output of your brain, period. Hard stop. Whether you have back pain or you just broke your arm and you can see the bone coming through the skin, it is still an output of your brain. And so, pain psychology is not the when everything else fails intervention because you just must be crazy. No, like, it's really meant to be a first line treatment. And if it were being offered sooner, in part because we have limited resources, we could really help people early on in their pain journey and likely reduce the chronification of a lot of these complaints and really help them to not get in a 10-year cycle of disability where they're doing less and less and having more and more pain, but instead reverse that earlier when they're not so deep in that spiral.
That was a mic drop. I think we can just end the whole interview now. That was great. I mean, that's exactly how I see the role of pain psychology, and I often see the idea of pain. The inherent nature of it being subjective is what really frustrates me about when it comes to trying to get things approved through insurance or saying someone didn't meet enough NRS scale. Because, to someone, a 9 out of 10 pain that went from a 10 out of 10 pain is enough for them in life to say, I'd like this intervention again. And, I realize that the limited resources sort of are at odds with that, but it still is kind of a frustrating space to be in when you want to just help someone, but you can't really reach out to them because of our inability to accommodate the subjectivity of it. But speaking of that and incorporating pain psychologists, how do you find the role of working with, pain physicians or pain PT or pain occupational therapists or chiropractors? How is a multidisciplinary approach for you within this realm?
So I have been fortunate to be able to work in multidisciplinary teams from early on in my training. I did some rotations in a pain clinic in Indianapolis, which is where I did both undergrad and grad school. And this was a private practice pain clinic, but it had psychiatry, OT, nursing staff, podiatry, psychology. I mean, was really occupational therapy. I'm not sure if I said that. So it was a really comprehensive clinic, and that was amazing. And then I went on to work. I do my internship at VA Boston, where I spent my time primarily in rehab. So lots of veterans with spinal cord injuries and other conditions that they were recovering from. And again, I got to work in these interdisciplinary teams. It's amazing to be able to share our expertise with the physicians or the PTs and the OTs. I would go in during PT and OT sessions to help patients better manage their pain, or to identify what we could work on during our next session together. Where were we seeing the barriers? So I think that this is, it's where it has to be. Like, pain is such a complex condition, and it's really best addressed when we're tackling it from every angle.
Are there things that you tell your patients that they can start doing now? As you had mentioned, a lot of therapies like CBT, ACT, require multiple sessions, sometimes, like you said, 6, sometimes 12. What are some things that you tell patients that they can start doing right now?
So the really low hanging fruit, start with deep breathing. Like, you can find it, Google diaphragmatic breathing or deep breathing exercises. My favorite app is called Insight Timer. I use the free version of that with patients all the time. Do that for 5 minutes every day. Work on starting to engage that parasympathetic nervous system and downregulate your nervous system. That's an easy lift. Try and pace your activity. Take frequent breaks. Then go back to doing the things you were doing. Don't do it all at once and then be down for the count for days or hours. Do gentle movement, really short walks. If you're struggling to even get out of bed or off the couch, then maybe that walk is a lap around the inside of your house, or maybe it's just down your driveway and back, right? Whatever's just a little bit further than what you're already doing. And then add something enjoyable to your day. This could be a cup of tea, reading a book, listening to your favorite album, petting your dog or your cat. So often we're all focused on reducing the bad stuff like pain and depression, that we really fail to add in the good stuff. And these are resilience factors. And we are learning more and more that we not only need to reduce risk, but promote resilience. And this is how we do it. And all of these small steps add up.
And then lastly, what would you recommend patients look for in a pain psychologist? Or if they start looking for a pain psychologist now, what would you recommend to them?
So you want somebody who is trained in health psychology or behavioral medicine or has worked with populations who have chronic illness. You want to make sure that they have training in evidence-based practices. All of the things I've mentioned today are all evidence-based. So cognitive behavioral therapy, CBT, ACT, pain reprocessing, EAET, also things like mindfulness-based stress reduction and other mindfulness-based interventions. There's also now like somatic interventions. So there's lots of modalities that people can choose from. If you have a history of trauma, I would highly recommend making sure that the person has a trauma-informed approach and asking that person before you really start working with them. You can check the APA directory, so American Psychological Association. You can check into some pain organizations. But where I usually go, there's a website called psychologytoday.com. You put in this. Nowadays, I usually just do state because most people want virtual. So the state you're looking for, whether it's in person or online, you can put in your insurance information and then your chief areas of complaint. So, they have chronic health and chronic pain as one of those. You can identify male or female if that's important, and really get an idea of who these folks are to be able to see if they might be somebody that you could work with.
Excellent. That's awesome. Dr. Meints, thank you so much for your time and valuable insights. I have probably a million other questions I could ask you, but you have a limited amount of time, and I really appreciate you taking the time today.
Yeah, thanks so much for having me, Derek. This was great. I hopefully have provided people with maybe a little suggestion to either refer their patients over to us or to seek out care on their own if they are a patient.
Absolutely. Have a great rest of your day.
Bye.